Okay, good morning. We're going to wait just a moment as people enter the room, and then we will get started once our participant numbers slow down just a bit. Great. We are going to go ahead and get started. So good morning and welcome. I am Stephanie Costello, Director of the Partner Relations Group and the CMS Office of Communications, and I'll be your moderator today. Today's stakeholder call is an opportunity for CMS to provide an additional update on the final national coverage decision for treatment of Alzheimer's disease with monoclonal antibodies directed against amyloid, and to provide an opportunity for stakeholders to provide feedback and ask any clarifying questions. This session is being recorded for our records only. Please do not speak if you object to the recording. Also, this call is not for press. Like everyone, press are welcome to listen to the call, but press questions need to be directed to the press office's resource on the cms.hhs.gov website or sent to press@cms.hhs.gov. After some brief initial remarks, we will open the floor for discussion. If you wish to comment or ask a clarifying question, please type it in the Q&A box located at the bottom of your screen. We will also be giving you the opportunity to raise your hand through the raise a hand function and ask a question verbally. We will do our best to get to as many questions as time allows. Do note that we are only able to focus on questions related to coverage or the process in developing the NCD. We're happy to hear your comments as well. While we may not be able to answer all questions, it always helps when we bring back your questions and comments to inform future efforts. And with that, I'll turn it over to Dr. Lee Fleischer, the CMS Chief Medical Officer and Director of the Center for Clinical Standards and Quality, CCSQ, and to Tamara Cyrick-Jensen, Director of the Coverage and Analysis Group in CCSQ. Lee and Tamara.
Thank you all for joining us today about the final national coverage determination for monoclonal antibodies directed against amyloid for the treatment of Alzheimer's disease. I want to start out by saying that we greatly appreciate the engagement by all stakeholders on this important decision. We received more than 10,000 comments. We heard you. We followed the science to make changes to the proposed decision. The final decision was driven by science by being based on the evidence and stakeholder input. CMS follows a long-standing process developed by Congress to determine whether an item is reasonable and necessary for the diagnosis or treatment of an illness or injury to the Medicare population. This evidence-based approach included review of more than 250 peer-reviewed documents. The final decision ensures access to and coverage for Aduhelm and other drugs in the class that receive accelerated approval through FDA or NIH-approved clinical trials across a broad scope of care settings. The decision also supports innovation and certainty of coverage by creating a long-term coverage pathway for new drugs in this class that obtain FDA approval without requiring a new national coverage determination. Tamara will discuss these pathways in more detail momentarily. As we think about Medicare coverage, it is important to remember that we are talking about a drug for mild cognitive impairment. This drug is directed at patients who are reasonably healthy and who may not have outward signs of dementia. As a physician, I know that there may be potential for promise with this treatment. However, while the drug is known to reduce amyloid plaque in the brain, there is not currently evidence that this reduction leads to a clinical benefit in the form of improved cognition or function. In addition to the uncertain clinical benefits, the known risks associated with this drug include potentially fatal brain bleeds. We understand that investigations are underway of 4 patient deaths. Taken together, there is not currently sufficient evidence to support full coverage of this drug for people with Medicare under the statutory reasonable and necessary standard. CMS will gather additional evidence on the effectiveness and safety of this drug by supporting rigorous studies by the FDA and NIH to help determine if there truly is a clinical benefit for Medicare beneficiaries for drugs in this class. Future drugs that are in the pipeline and demonstrate clinical benefit will be covered so that patients have access. Coverage for these drugs will not require a randomized controlled trial. We anticipate that coverage in this case will include a data collection such as a registry. We look forward to seeing the evidence for drugs in the pipeline. We will continue monitoring future developments in this class of drugs, and we are committed to exploring ways that we can improve care for people with Alzheimer's disease. At this time, I'll turn it over to Tamara to discuss the final decision in more detail.
Thank you, Lee, and good morning, everybody. I'm going to share my screen and go through the specifics of the final national coverage determination. All right, can everyone see that?
No.
No.
All right, let's try that again. How about now?
Yep.
Thank you.
Thanks.
Perfect. Thank you. So as Lee mentioned, on April 7th of this year, CMS announced a final national coverage determination that covers FDA-approved monoclonal antibodies directed against amyloid for the treatment of Alzheimer's disease when furnished in accordance to the coverage criteria specified under coverage with evidence development for patients who have a clinical diagnosis of mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's disease dementia. Both of these must be confirmed with the presence of amyloid beta pathology consistent with Alzheimer's disease. So CMS created 2 coverage pathways depending on the FDA approval of the treatment. The first coverage pathway is for any monoclonal antibody directed against amyloid for the treatment of Alzheimer's disease approved by the FDA using surrogate endpoints considered reasonably likely to predict clinical benefit. And these treatments may be covered in a randomized controlled trial conducted under an FDA investigational new drug or IND application or a National Institutes of Health supported trial. We note under this first pathway that there is no requirement for CMS to review or approve any of these studies. And then for the second pathway, for any monoclonal antibody directed against amyloid for the treatment of Alzheimer's disease approved by the FDA using direct measures of clinical benefit may be covered in a CMS-approved prospective comparative study. We note that any CMS-approved study may be collected, the data may be collected in a registry. In addition, similar to the first pathway, any National Institutes of Health supported trial is also covered under this pathway. For any NIH approved, or for any NIH supported trial, CMS does not need to review or approve those specific trials. So under coverage with evidence development, for any CMS approved study, the criteria in order for us to approve it includes that the protocol, including the analysis plan, must include a study population whose diversity of patients are representative of the national population with mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's disease dementia. A neurocognitive evaluation and a description of the instrument used to assess cognition and function for the clinical diagnosis of mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's disease dementia for study enrollment and outcomes assessment must also be included in the protocol. In addition, in the protocol, a description of the multidisciplinary dementia team and optimal medical management, as well as study sites with clinical expertise and the infrastructure to provide treatments consistent with safety monitoring outlined in the FDA-approved label. Similar to all of our other national coverage determinations that require coverage with evidence development, questions must be outlined and answered in the protocol. For this specific national coverage determination, all of these questions must be answered, which include, does a monoclonal antibody directed against amyloid for the treatment of Alzheimer's disease meaningfully improve health outcomes? That is, does it slow the decline of cognition and function for patients in broad community practice? Do the benefits and harms such as brain hemorrhage or edema associated with use of the monoclonal antibodies directed against amyloid for the treatment of Alzheimer's disease depend on characteristics of patients, treating clinicians, and settings? And last, how do these benefits and harms change over time? And then, like every other coverage with evidence development national coverage determination, there are basic CED criteria, A through M, that can be seen in the NCD and the link that we have here. And I recommend you take a look at those as well. In addition to what I have outlined earlier, we also included in this national coverage determination for any CMS approved study, NIH supported study that includes a beta amyloid positron emission tomography or PET scan as part of the protocol. It has been determined that these trials or studies meet coverage with evidence development requirements included in that particular national coverage determination, that is the beta amyloid positron emission tomography or PET in dementia and neurodegenerative disease national coverage determination. And then anything that I did not mention that is outside of this national coverage determination, so if the treatment is not included in an FDA, NIH, or CMS approved trial, it is considered nationally non-covered. Thank you. And then any other questions? Adam?
Great, thank you, Tamara. And good morning, everyone. I also want to echo my thanks for your participation in today's call. As we get started, I'd like to remind everyone on the call that we are extraordinarily eager to hear your feedback, and if there are any clarifying questions that you might have. Of note, we will only be able to address those questions related to the coverage process and the recent coverage decision that Stephanie mentioned earlier at the top of the call. We'll certainly be monitoring the Q&A box during the session. If you want to ask a live question, please use the raise hand feature, which I believe is at the bottom of your toolbar. Once you are recognized to speak, you can unmute, or we'll unmute you and make your comments or ask your question. We do ask that you keep your remarks concise so that we can hear from as many participants as possible within the time that we have remaining today. Now that we've covered the ground rules, I think it's fair to get started. So to ease us in and to just give everyone a chance to find the raise hand feature and get comfortable, I want to start by offering a question to you, Dr. Fleischer. And that question is, specific decision have any bearing on other drugs in different therapeutic areas that are approved through the accelerated approval process?
Thanks so much, Adam. And we have heard this question, and a recent decision should not be viewed as setting a new direction on therapies that receive FDA accelerated approval. CMS has long covered drugs that have gone through FDA accelerated approval previously, for example, to treat cancer and HIV. This was an uncommon situation with the monoclonals for the treatment of Alzheimer's disease, where we were looking, at a drug in this class that received accelerated approval based on evidence that it reduces plaque on the brain, but unclear evidence that it translates to health outcomes like cognition and function. And was tested on relatively healthy patients. Thank you.
Excellent. Thank you, Lee. I'm going to go ahead and just take a look at our attendee list. For those who have their hands up, we're going to try to do this democratically, and I'll go down through the list. Again, please keep your remarks as concise as possible. Let's start with, and again, pardon any mispronunciation. I will just say that I'm going to do my best here. So let's start with Andrew Cosgrove. Could we unmute Andrew, please?
Okay, can you hear me?
Yes.
Oh, great, thank you. Thanks for doing this. This is great. How will the agency ensure that that the NCD will allow for the evaluation of each drug that may be in this class on its own scientific merits? And specifically, how will you be leveraging the reconsideration process to achieve this?
So we have been working with the manufacturers and the FDA. And so the manufacturers can submit any new evidence at any time, similar to how we handle all of our national coverage determinations. And if there is any new evidence, we can reopen this NCD at any time to reconsider our coverage determination as a class or on a specific drug.
Thank you, Tamara. Let's go to Suzanne Dowd-Galley. Could we unmute Suzanne, please? Do we have Suzanne?
I don't see that last name.
G-A-L-L-I?
No.
Okay, we can come back. How about, let's move to Amanda Hugh.
Hi, thanks so much. So my question was, you mentioned that the decision in particular in this situation was based off of the data surrounding the surrogate endpoint for monoclonal antibodies targeted at amyloid beta. And so I guess my question is, given that the accelerated approval pathway is specifically meant to provide an accelerated pathway for drugs for serious conditions that fill an unmet medical need based on a surrogate endpoint, does that mean that CMS sees itself as playing a role in determining what qualifies as a valid surrogate endpoint, and how will it be dividing those responsibilities with the FDA, or how will it be coordinating that?
So thank you for the question. And so let me just start that the FDA and CMS have different statutes and different missions. And so as Dr. Fleischer started off with his introductory remarks, under the Medicare statute, it is our responsibility to determine whether a particular item or service, and in this case, the drug, is reasonable and necessary for the treatment of an illness. And based on over 250 pieces of evidence, we determined at this time that it is only reasonable and necessary in the context of an FDA IND trial or an NIH trial. This was based on, as we reviewed this, we're talking about relatively healthy individuals, and we know that there are harms with this drug. And we wanted to find a path forward. And so that is why we cover this in supporting our sister agencies, the FDA and NIH. And then when it moves to the next level for FDA approval, then there is broader and coverage to a wider array of patients as well as places of care. Thank you.
Thanks so much.
And just to reiterate the comment Tamara said, we are working closely with our sister agency to coordinate and have these discussions. And as I noted about HIV and cancer, which have gone through accelerated approval, there it's well defined that those surrogate outcomes, viral load, tumor size, are linked and do meet our statutory obligation. Thank you.
Great, thank you, Amanda. I believe we have Suzanne now.
I noticed the study group was just for mild dementia and for mild Alzheimer's disease and dementia. Are all the beta amyloid amounts based on PET scans in those studies? And will that change for additional studies? Will you be able to include a broader range of Alzheimer's patients besides mild dementia?
So under our national coverage determination, the patients the patients follow what is in the current FDA label. So it's patients with mild cognitive impairment. But to your point of whether we can expand it to a wider number of patients with different diagnoses, certainly we can do a reconsideration at any time. And based on the evidence, we can certainly widen the patient criteria.
But additionally to your question, the patients who are entered into the clinical trial for approval, both for the accelerated pathway and the final pathway, are a determination by the companies at working with the FDAs, and so urge you to ask the question to that group.
Okay, thank you.
Thanks, Suzanne. Let's go to Ian Kramer.
Hi. Audio coming through okay?
Yep, we've got you. Thanks, Ian.
Hi, everyone. Ian Kramer from the LEAD Coalition. Thank you very much for holding this second session and for all the extraordinary amount of work that has gone into developing this NCD and reading all our comments. So a quick observation and then two quick questions. Dr. Fleischer, on this call, and I believe on the preceding stakeholder call, if I heard you correctly, you characterized these therapeutics as being targeted at people with mild cognitive impairment, which is certainly true. But each time, at least as I heard it, you did not mention that they are also targeted at people with early stage dementia. And that is very much part of the written document, which I appreciate and I think is important as a scientific and clinical issue. I would just ask you in your future discussions publicly about this to identify both of those categories and to not leave any inadvertent impression that CMS either substantively is limiting this to MCI or that CMS somehow misunderstands that these drugs are only targeted at MCI. And particularly when you are characterizing folks in this category as reasonably well. I would contend that many people with MCI and certainly with early stage dementia are not reasonably well and do not perceive themselves as reasonably well and clinically are not reasonably well. And so I think we're all sensitive to the language and I know you're doing your best. I would just ask you to double down on being inclusive in your language. For the two questions, which I will try to be succinct about, and this is just to help me understand better. Is there some precedent in terms of CMS coverage for this what I will call a bifurcated process where accelerated approval products have to have an RCT, but traditional approval products in the same class don't have to have an RCT. They can have this more broadly defined CED kind of study, which I will loosely call real world evidence development. I'm not sure that's technically on point, but I think you get my gist. And then the second technical question is, for products that get accelerated approval under this NCD, and so they have to do the RCT, if I've read the document correctly, after the RCT, they still need to develop that kind of real world evidence. Is it within CMS, does CMS see it as permissible to run the RCT and the real world evidence development concurrently rather than consecutively, just as an efficiency issue to get at the answers faster? Thank you for allowing me to take that time.
And I want to start by just thanking you for the comments, and we will ensure that we are accurate to both the label and the inclusive population. And I'll turn it to Tamara to really discuss in more detail why we could have limited this to the original proposed decision, why we felt it was important to provide clarity of the direction of our coverage in developing that second pathway based extensively on the comments. So Tamara.
Thanks, Ian, for those comments. Really appreciate that. And I definitely will make sure my language is more precise and accurate moving forward. So as Dr. Fleischer said in his introductory remarks, this is a relatively unique situation in that we are making a national coverage determination on a drug. And so, one, this is unique. For national coverage determinations in general, there is some precedent where we have done, we've covered some part of it, and then we do some other indications under coverage with evidence development, and then some indications where we nationally non-cover. So there is precedent in doing different decisions within the national coverage determination. As far as your question, which is a good question, and I would need time to think through that and compare on what is the language that is in the national coverage determination, and maybe I can follow up with you to more fully understand what you're suggesting, which is an RCT, a randomized controlled trial, and then at the same time, using your words, doing this real world evidence study as well. So let me follow up with you on that to more fully understand that, to see if that is a possibility. I think at the end of the day, yes, we want to get the right evidence very quickly. So let me just wait on that answer because I don't know the precise answer today, and I will follow up with you. Thank you for that question.
Thank you, Tamara. And just to clarify on my first question, I really am curious about precedent for specifically the bifurcation between accelerated approval and traditional approval within the same class, and particularly for therapeutics rather than, say, diagnostics or something else. But I've taken enough time. So if you can respond to that distinction, I'd be grateful.
So this is a unique national coverage determination. And so we have relatively few, I can't think of, maybe a handful that are specifically on drugs. And so this NCD is unique and is not our intention to do many national coverage determination, if any, on drugs.
Thank you, Tamara, and thank you, Ian. Really appreciate the comments and the questions. Let's move on to our next participant. Let's go to Michael Ellenbogen. And Michael, I'm sorry, I saw that you had put in a request to speak at the top, so let's go over to you.
Can you hear me?
Yes, we can.
Thank you so much. And I appreciate this meeting. And please bear with me because I not only live with dementia, but I'm actually brain fogged from having COVID right now. I just want to make some comments here. I know so many people with dementia who was relying on this particular drug. Me personally, I cannot benefit from it because I'm way past the stage for the use of this drug. But talking to my neurologist, who is also a scientific person in dementia, he has had to take away this drug from people who are in drastic need of using this drug. They got their heart ripped out from their crying because they can't use it. One person has been taking this drug I apologize, I don't know what type of dementia they have, but it's a very progressive dementia. And they really needed this drug because they thought it was helping them. And I can't say it is or it isn't, but they thought it was helping them. So it just ripped their heart out because now they have no alternative. And this was the only hook that they had. There's also the issue that I think people aren't recognizing as you want this drug to be in clinical trials, but sadly, the people who need it the most in clinical trials can't benefit from it because the minorities who rely on this are not in locations where the clinical trials are able to be taking place. And that's a real injustification to those folks. So I would hope you would relook at some of this because I can't begin to tell you how many people with dementia are heartbroken at this point in time. And from my point of view, I took Aricept. It works for 50% of people, and for 50% of people don't work. It had major side effects to me, but I was willing to live with those things because it helped me. It helped my brain. But at the same time, we should be given that choice. There's many other black box things that CMS is covering today that are worse off than this drug. So I think we should allow the people who are living with the consequences to determine whether it's worth dealing with these issues or not. Thank you so much for taking the time to listen to me.
And Michael, thank you so much for expressing your comments, and we hope that the brain fog from COVID continues to improve over time. We know how devastating dementia as well as the cognitive changes from COVID can be. I can assure you we heard from the advocates many of the comments you made, and were a large part of our decision process. But in addition, we heard from lots of the specialty societies, the scientists, and other colleagues that really informed the overall decision process. So we continue to work with those colleagues, but it was we took all of that into account when we made this final determination. Tamara, any additional comments?
Thank you, Lee. Thank you for those comments. Really do appreciate them. And I do hope you feel better and fully recover from COVID. So similar to what Lee said, we definitely want to get drugs that work into the hands of patients who need them. And that is why we issued a coverage with evidence development national coverage determination, so that we can figure out what works and what doesn't in the context of studies, and to get this information to all of the physicians that are treating patients. Thank you.
Thank you so much, Michael. We really appreciate you sharing, and we're absolutely here to listen, so thank you. Let's take our next participant. How about Al Dobson? Can we unmute Al?
Can you hear me now?
Al, yep, we've got you.
Oh, okay, thank you. I'm Al Dobson from Dobson DeVonzo. We're a CMS evaluation contractor. We use a lot of claims data. And I was wondering how much you thought about using claim data to track your patients with and without the drug. As you know, with claims data, you would have 100% coverage. And now your claims data are so fast, you have a 3 to 4 month time lag. They're almost real time. And if you think about it from that perspective, you have infinite patient coverage. And from that perspective, your claims data are actually the ultimate source of real world evidence. I know they have a lot of clinical issues, but nevertheless, they have so much power to follow and track the kinds of things you're talking about. Perhaps after you get into clinical trials, you could wrap the claims data around them so you could follow people through all their expenditures and all their Medicare events, and then have a very powerful way to continue to track the development of this without much less expensive than the clinical trials that you're about to undertake. Thank you.
Thank you so much, Alan. I am actually a health services researcher and do claims analysis too. And we, as you looked at our coverage decision, we do feel strongly about the initial part about the randomized trials. But as we get into what we call as the second phase or the part 2 with the traditional coverage, the determination, importantly, that FDA has determined that there's a clinical benefit and therefore meets our statutory authority, that in fact, we are looking at all forms of potential analysis to meet that criteria. So we look forward to engaging the ecosystem during that part of the discussion. Thank you.
Thank you.
Great, thanks, Al. Let's go to Eugene Jiwanmo. Hope I pronounced that correctly, and I'm terribly sorry if I didn't. Eugene, do we have you?
Yes, can you hear me?
Yes.
Yes, no, you did a good job. It's a very tough last name. It's Jiwanmal. So Eugene Jiwanmal from Independence Blue Cross in Pennsylvania, Philadelphia, Pennsylvania. Obviously, we are a Medicare Advantage plan with CMS. Appreciate all the hard work that CMS has put in this and the decisions that they have reached. Just wanted to clarify something, and I've been trying to get this answer for a while in previous calls as well. Has CMS determined the significant cost threshold? And I did put in a detailed manner in the Q&A and also chat my question. In order to understand, whenever there's a CED, obviously there's a significant cost threshold that determines who's going to be responsible for the reimbursement piece. Is it the MA plan versus CMS? And we've been trying really hard to get that answer from several places. When will it be determined by CMS? How will it be communicated? Because we have to get our policies out and provide coverage for our MA members. And one added piece to this is obviously this is for all monoclonal antibodies in this space upcoming. So we would need to know that for Aduhelm, and then obviously what is the plan for future agents as well.
And just trying to determine, are you asking for the cost threshold for making decisions on coverage?
No, this is the significant cost threshold that is, I'm sure somebody from CMS will know what I'm talking about. This is, if you go to the actual NCD for how CDs are determined and all that, it's a part of that.
Tamara will answer that part. I just want to make it clear to everyone else that we do not take costs into consideration just for the entire group. That is why it's actually under a career physician and the coverage group separate entirely from the payment side of CMS.
Yes,
Tamara?
I do agree with that,
Okay.
Dr. Fletcher. I completely understand, and we actually appreciate that because that's how we make our decision too. But in the continuum of providing coverage, you do understand that after the NCD comes, the next piece is, okay, let's reimburse for the providers and the members for it. So that's where I'm just connecting the dots.
And I think those are, Tamara, please, Tamara.
So thank you for the question. Yes, I am very familiar with the significant cost threshold and work closely with our partners in the Medicare Advantage group, our colleagues in Medicare Advantage. We are currently working through that now, and they are not on the line today. Those experts are not on the line today, but I know that they have normal communication methods that they will get that information out to all of you, hopefully in the near future. But yes, those conversations have occurred internally. And so now we just need to communicate what that answer is. Thank you.
Thank you so much. All right.
Okay, great. Thank you. Let's move on to John Dwyer. Do we have John Dwyer? John, we see you, but you may be on mute. Maybe we can help John just move on.
No, yeah, we'll move to the next person. You have to unmute, John, on your end. Or if this is a mistake. Well, move to the next.
Let's jump to the next, and hopefully we can get John back on the line. How about Michael Ward?
Hi, good afternoon. I just want to ask a quick question. I think it may have been reflected in Niall's question in the box, but I know you mentioned a commitment to quickly reconsidering the NCD once an anti-amyloid drug has answered the CED questions of quality evidence. So I guess I wanted to ask about the timeline for reconsideration. I mean, I think that's a piece of how quickly you would accept, the process would take to consider a request for reopening the NCD, and then how quickly you believe the reconsideration process would go. Would it be the typical, 6 to 9 month process that we see with these types of things, or do you anticipate a shorter time frame, and what would you anticipate the target for that would be?
Michael, thank you for the question. As you know, there is a process that is outlined in the statute for national coverage determination. And so the agency must follow the national coverage determination process with the statutory timelines outlined in the statute. With that being said, the agency certainly intends to be flexible and nimble. So depending on the strength of the evidence, if there is new evidence and it's significant, certainly we will react very quickly and open up that national coverage determination. And then depending on that evidence, we'll then determine how quickly we can reconsider it. But we know that it would not be longer than the statutory timelines that are outlined.
Okay, and is there a definition or a particular threshold clinically that you all are looking at to determine what would be significant?
As we've outlined in the determination, one of the ways we've done that, as far as at least to go to pathway 2, is working with our FDA colleagues and their determination with regard to traditional approval based upon health outcomes. Tamara, anything additional?
No, I think that's right. And so, we are looking forward to engaging with, when we move to that, we're looking forward to seeing the data as it comes out of all of the randomized controlled trial or any studies that come out of NIH. At the end of the day, we are looking for improved health outcomes, and then using the measurement or the tools that are being used in many of these trials, like the CDR-SB. And we're looking forward to engaging with the sponsors to propose their protocols, as well as how they're going to answer the CED questions.
Thank you.
Thank you, Michael. I believe I had seen Sean Tunis with your hand up. We still have Sean? Maybe. There we go. We see you now, Sean.
Yeah. Can you hear me okay?
Yes, thank you.
Yeah, hi. So just add my congratulations for the CMS folks. Enormous effort on this. I can't imagine how you made your way through 10,000 comments, many of which were quite lengthy. So my questions are just a couple of clarifications about the CED studies. Oh, and by the way, as you know, or may not know, I've been working with Us Against Alzheimer's. We've been thinking about how to develop real world evidence in the context of, potentially in the context of CED studies. So the first question is about the language prospective comparative studies, potentially using a registry. I assume that means that the registry would have to be able to enroll people who are on therapy and not on therapy in order to be a comparative study. And I just wanted to see if that's what you meant by comparative. And part two, the second question is, you had language in the decision about like the nature of this acceptable CED studies would have some bearing on the strength of the underlying evidence for cognitive benefit in the approval studies, in the pivotal studies. And I was just wondering if you could say a little bit more about what that, I presume that means that if there's greater, more definitive cognitive benefit, that you may be receptive to less rigorous study designs, but I'm not sure. I'm just trying to get a sense of that.
Thank you so much, Sean, and it's a privilege to have a former CMS Chief Medical Officer on the call with us today, just to acknowledge. And I think as we added the comparative, we're really looking forward to engaging with the stakeholders of what they think is an appropriate comparative group. And so I don't think, unless Tamara has other definitions, that we are welcoming what that comparator is to whoever's in the real world evidence or the registry. So we don't have a predefined concept at this point.
Sean, I think that's right. And I think to your latter question, I think you've got it right. There's a wide range of what could constitute as an appropriate comparator, and it depends on the state of the evidence. So the greater strength of the evidence in the initial randomized controlled trial, then I think you're right, the less rigor that might be needed in the follow-up coverage with evidence development study. Thanks for the question.
All right, thank you.
Thanks, Sean. Let's go to Max Linder next. Max Linder.
Hey there, can you hear me?
Yes, we got you. Thanks, Max.
Hi, thanks. I'm Max Linder with the American Academy of Neurology. First off, again, as everybody's been saying, congratulations and excellent work on what must have been a grueling NCA and NCD process. We were really pleased with a lot of the changes from the proposed to the final, but one of the questions we had, and the AAM was actually cited in the section describing the multidisciplinary care team requirement. I just wanted to ask if the requirement to define the multidisciplinary care team for trialists when submitting to CMS, is that, can you elaborate on what that requirement is to just define it? Is there some standard or set of requirements that you guys are looking for, or as it seems to be throughout the NCD, you're trying to be deferential to trialists while still making sure that you're getting the information and kind of being inclusive of what we need?
I was waiting for Lee to see if he wanted to take that one. Thank you. So yes, you're absolutely right. We just want the description in the protocol to make sure that it's there, but we're not defining what it might look like. And so there's a lot of latitude in that particular requirement, but I think you've described it well.
And we really want to thank all the specialty societies and others who have made comments, and look forward to both the American Academy of Neurology and the other specialty societies to help inform as we go further forward. So thank you.
Thanks, Max. How about, let's see who we have here. Patricia Bensavenga.
Good morning. My name is Patricia Bensavanga, and I am the Special Projects Coordinator at Farmed Out, a Georgetown University Medical Center project that advances evidence-based prescribing. Farmed Out would like to thank CMS for their coverage decision on Aduhelm and other drugs like it. Aduhelm is ineffective and dangerous, and with this decision, CMS is protecting dementia patients and patients with MCI from drugs that have questionable effects. And this decision will support clinical trials to determine if a monoclonal antibody directed at amyloid will have positive clinical benefit in the future. So thank you.
Thank you, Patricia. Really appreciate the feedback. Let's see. How about George Brandenburg? Do we have George?
Can you hear me?
Yes, we got you. Thanks, George.
I thank you for having these sessions. I think they are very useful in informing the field about your thinking and about your processes. I have a question about sort of the track in which we have a randomized control trial, either for the FDA or for you, in which there is a meaningful clinical benefit shown. And now we're entering a CED study phase in which a registry or other means of determining clinical benefit at a clinical practice level is to be determined. What is the process that you contemplate for approving the study designs at that stage? What kind of patient access to the drug during that period of time do you anticipate? Registry could be 5 or 10,000. And how long do you think those studies might be required? Because during all of this time, clearly patients are not getting access to this drug to the FDA label, which they have approved in a traditional format, has demonstrated meaningful clinical benefit. And now the drug company has had to go through this study phase. So it's just probably another several years. So do you are you going to approve those study designs? What kind of patient access do you anticipate during those phases? And how long do you think that they will take?
I'll just start, and thank you so much, George, for today and engaging with us prior to today on behalf of the individuals you represent. Just want to make it clear, CMS on the first stage, I know you said CMS approved trials, it's actually NIH approved trials. And really what we've heard from the administrator and how we've thought about this is, as if the study designs are appropriate, as wide as coverage to the label as possible. So I'll turn it over to Tamara for the specifics with regard to how we'll look at those trials.
George, thank you for the question. Always appreciate the energy and passion you bring to this discussion. The intention on the second path is the intention was that there would potentially be wider access. We're not limiting the place of service. We're not limiting the number of patients that could be in these studies. And so we are hoping that there will be broad access. Some of the examples that we have had under coverage with evidence development there have been, around 275,000 patients. And so we're really looking to the sponsors or anyone that wants to submit a study to CMS. It doesn't have to be limited to 1,000 or 2,000. It can be very, very broad as long as it meets the criteria that we have in the national coverage determination. I hope I've answered your question. Thank you.
And just to lean into a previous answer in response to Sean Tunis, the strength of the evidence with regard to the efficacy of the drug will inform us significantly in the structure of any of those subsequent studies. So thank you.
I appreciate that, but the duration of those studies could be lengthy or not, I guess, depending upon the protocol approved. But you will have a process by which sponsors will come, sponsors or patient organizations would come to you and propose a protocol for those post RCT studies?
Sorry, I had trouble with my mute button. Yes, we do have a process to approve coverage with evidence development studies. And the process does move relatively quickly. But I think the key for us to approve these coverage with evidence development studies as soon as FDA has approved in the next level of their approval process is to engage us early. And so anyone that is interested in doing that coverage with evidence development study that's more broad, wider access, is to engage with CMS early.
Great. Well, thank you, George, for the feedback and the questions. Really appreciate it.
Thank you for the responses.
Absolutely. Thank you. I know we are getting closer to the top of the hour. I think we can squeeze in another caller. George DeViglis, do we have you? I know you've had some technical difficulties, but hopefully we can get you on here. George, we see you.
I'm here.
Great.
I'm his wife. I'm power of attorney on my husband, who's a stakeholder. He was in the 27-month study with biotech, but he was on the other study. There was two. The one was working for him and it got canceled. Then I talked to his neurologist and that drug was being offered, but it was way higher than we could afford. I'm going through a lot with him right now with his benefits and stuff because my power of attorney isn't being recognized through the company, but I received the paperwork and was really excited that he might qualify for this. If this makes any sense to you, I'm absolutely devastated. And I hope that's a question you can answer. Can you hear me?
Thank you. Absolutely. Absolutely. One, thank you for sharing your story and all that you are doing for your husband. We do appreciate that you are participating in the trials. The manufacturers are saying they are working with many patients that fit their patient criteria. And so we do encourage you to continue to work with your physician to help you get your husband enrolled in the trial that you are referring.
Well, the thing is, I called his neurologist in Georgia yesterday, and Emery's not participating in it. George is going through the process of another study, and it's 5 sessions to see if he qualifies. But the doctor told me the side effects, like the swelling of the brain and stuff. He did say that George responded really well to the other study and that he could possibly do the same thing. But I'm forced into a decision of that's really difficult for me. I put him in this study if he qualifies as a stakeholder, and I put him in and he has all the side effects, or do I can't? I'm confused on what to do.
No, and thank you. And we can hear the angst in your voice. And many of us have been touched by dementia and Alzheimer's disease in our families. I mean, it's rare for someone not to feel that. And I know the administrator frequently spoke about that. All we can say is that the trial designs are really the company and working with the FDA and working with your primary neurologists. So, unfortunately, we at CMS, cannot help in that regard. But again, we wish you the best in solving that issue.
Will I get more communication though?
Again, we are not involved in those trials, so it would be best to communicate with the neurologist and potentially the company. But thank you for your question.
Okay.
Thank you so much. We truly appreciate you sharing your story. Stephanie, I think we're at time, so I'm going to turn it back over to you.
Great. Thank you so much, Adam. And thank you so much for all of the questions and comments today and for joining us and for those who were just listening. We appreciate that. I'm going to turn it over to Tamara. I think she has a few closing remarks before we end today.
Thank you, Stephanie. Thank you, everyone, for participating today. We really appreciated all of your questions, and we'll continue, and we will take all the questions that we saw in the Q&A and share them with our colleagues across CMS, and continue to encourage all of you to engage with CMS. Thank you again.
Thank you, and this concludes today's call.